Okay. So the cardiovascular and lymphatic systems are critical for maintaining fluid balance, blood pressure. They are delivery systems for hormones, nutrients, water and electrolytes, heat, oxygen, okay, and immune components. The cardiovascular system is really a solution to a problem in evolution when life changed from single-celled organisms that relied on just membrane transport to multicellular organisms that had a more complex architecture. We had to have a way of getting them the building blocks and the energy they needed in order to function, while at the same time being able to remove waste products that were distantly located from the respiratory and the digestive system. Otherwise, there's no way the organism could survive. As a result, the circulatory system evolved as a solution to that. All right. Now, the circulatory system is made up of the heart, the blood vessels, and the blood that's pumped. Right. The right heart pumps blood to the lungs for oxygenation. The left side of the heart pumps blood to the body to deliver the oxygenated blood. As a result, the most powerful chamber in the heart is what's known as the left ventricle. Okay, that's the left lower chamber of the heart with the thickest walls because it works against the greatest resistance and has to pump blood to the entire body. Otherwise, there's no way that the tissues could survive. The right side of the heart only needs to pump blood to the lungs, which are right next door. And as a result, the pressures in this part of the system are much lower, and the strength generated by the right ventricle is not nearly as great. Although the volume of blood that leaves the heart on the right and the left side as the heart pumps is always the same under normal circumstances. So the idea here, right, is that the right side of the heart works against less resistance and has less power. The left side of the heart works against more resistance but has more power. And as a result, the stroke volume, which is the amount of blood that the ventricles of the heart, the discharging chambers, squeeze out with each pump, is under normal circumstances equal. If they become unequal, then the blood will pool. And we're going to find out down the road where that's going to happen. Okay. The heart is made up of three different walls. Okay. The epicardium is an outer layer of connective tissue. The myocardium is cardiac muscle tissue, and the endocardium is the inner lining. And then, of course, the heart is surrounded by a pericardial sac that is filled with pericardial fluid as a lubricant so that the heart can pump easily without irritation, inflammation, and scarring. We should also note that there's a fibrous layer to the pericardium that helps to latch the heart in place, attaching it to the top of the diaphragm so that as the heart pumps and engages in almost a spinning or a ringing motion, it doesn't lose its mountings with the blood vessels and the rest of the body. Okay, so it's a stabilizing portion of the heart. Okay, the chambers of the heart are the right and left atrium and the right and left ventricle. Okay, the way that blood goes through the heart, if we were to follow a particular volume of blood through the heart, is that blood returns from the body through the superior and the inferior vena cava. I'll circle them here. Okay. Superior and inferior vena cava. Let's do this in, I don't know, green. Okay. Superior and inferior vena cava. Okay. And then on the back side of the heart, there's another vessel called the coronary sinus. Okay. Which actually drains blood from the heart itself back into the right atrium. So total three vessels. That blood enters the right atrium. And as the pressures here build above the pressures in the right ventricle, the tricuspid valve, this guy here, will open and the blood will flow from the atria to the ventricles. Okay. Next place that the blood's going to go is that as the ventricle begins to squeeze, the pressure will shut the tricuspid valve and eventually build to the point where it will exit through the pulmonary semilunar valve into the pulmonary trunk, to the pulmonary arteries, to the lungs. Okay. And then at the lungs, the blood will pick up oxygen. Okay. The blood will then return to the left atrium through the pulmonary veins. You can see those here. Okay. All right. And then from the left atrium, we'll go through the bicuspid, also called the mitral valve, into the left ventricle, which will then produce sufficient pressure to open the aortic semilunar valve and send it to the rest of the body. Okay. Now, I don't want to give you the impression that the blood goes, boom, 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 boom. Okay. And that when the blood leaves a particular chamber, that chamber is now empty. All chambers are always filled with blood at all times. It's just that the amount of blood in the chamber varies depending on whether the chamber
Hello,
is
sir.
which is called
Hello,
systole,
sir.
or the ventricles or the chamber is relaxing, which is called diastole. Okay. So it's just the amount of blood in the chambers changes, not that the chamber is actually fully empty. Okay. So a couple
Hello,
of terms.
sir.
Yes.
Please, some people are trying to come into the class, but
Yes.
they can't get the access. Please, can you send the Zoom link and again, please?
Okay. It's the same Zoom link. Should be the same. Hold
That's
on just
what
a sec.
I told them.
Yeah, hold on. I'll resend
Mr.
it.
Okay.
Richard, we have
Yeah.
two, there's one that you sent by email and there's one that was in the discussion, I think the first.
Okay. Anyway, I wanted to introduce a couple of terms. Okay. And those couple of terms are end diastolic and end systolic volume and stroke volume. Okay. So your stroke volume is just the amount of blood kicked out with each pump. Okay. The end diastolic volume is the amount of the blood in the chamber when it's maximally full, and the end systolic volume
Ninatu bikante mise ma by chance dinona isi ma
is the amount. Hold on.
transfer on there.
Let me mute.
In between, that's what the same thing in that day.
Okay. And the end systolic volume is the amount of blood in the chamber when it has done its maximum squeeze. Okay. So the stroke volume is the difference between those. Okay. So the stroke volume is always the same on the right and the left side of the heart in a single cardiac cycle. Okay. The valves of the heart are what ensure that the blood flows in one direction. Okay. The tricuspid valve is between the right atrium and the right ventricle, and the bicuspid valve is between the left atrium and the left ventricle. Okay. They're called tricuspid and bicuspid because the tricuspid has three flaps, the bicuspid has two. Sometimes you'll see the bicuspid valve referred to as the mitral valve because it looks like a bishop's mitre. Okay. In the Catholic religion, the bishop wears a hat that has a point at the top, which are two flaps that converge, and that is similar to the valve between the left atrium and the left ventricle. Okay. The semilunar valves get their name because they have moon-shaped flaps. There's three in each semilunar valve that shut when the blood in the great vessels tries to get back into the heart. And because of their geometry, they don't allow the blood back in the other chamber. Okay. So you can see here, if we remove the atria, what the valves look like. Okay. See how the semilunar valves down there at the bottom are only opening into the great vessels. Okay. These are the semilunars. All right. And see how the AV valves, the left and the right AV valves, all right, are only opening into the ventricles. Okay. And that ensures the one-way flow of blood. If the valves get deposits on them, or if the flaps become loose, then the blood will flow in two directions when the heart tries to pump, and that'll be heard as a heart murmur. Okay. And what that does is it puts extra work on the heart and can, over time, cause the chambers to become overstressed and flabby and less effective at pumping blood. Okay. Something we should point out about heart muscle tissue is that it's designed never to go into tetany. Okay. Heart muscle tissue can't go into tetany. Okay. And the reason for that is that the refractory period of heart muscle tissue is very long, which means it's not possible to hit heart muscle tissue with so many action potentials that the space between contractions does not have a relaxation period. And that's important because if the heart muscle went into tetany, it could run out of energy and stop pumping. So biochemically, it's set up never to be able to do that. Now, that said, the heart can fail to pump blood if the pressure against which it works is greater than the pressure it can generate. Okay, the heart would continue to squeeze, but the valves may not open. And the result of that is that there be no blood flow. Okay, and that's a condition known as congestive heart failure. All right. And that's where the afterload that against which the heart has to work, which is the pressure it has to work against, is so great that the heart literally can't open the semilunar valves to pump the blood to the lungs and to the body. All right. And that's a risk factor in people who are um, obese. All right. Or who have a lot of deposits on their arteries, okay, such as an atherosclerosis, all right, or who have an abnormally expanded blood volume, all right, because that increases, again, the afterload. Okay. The great vessels of the superior and inferior vena cava, okay, those bring blood into the right atrium from above and below the heart, okay, and the pulmonary artery, which branches into the right and left pulmonary arteries. Sometimes this is referred to as the pulmonary trunk. Okay. The pulmonary veins, which bring oxygenated blood back to the heart, and the aorta, which is the largest artery in the body, which sends oxygenated blood out to the rest of the body. Okay. Now, a very important point here, which is that arteries always carry blood away from the heart. And veins always carry blood back to the heart. Do not get caught up in color. Okay. Color is just a state of oxygenation, whereas arteries are always away from the heart and veins are always back to the heart. Okay. Veins tend to have thinner walls, they have one-way valves, they have less smooth muscle in their walls, and they're under lower pressure. Arteries tend to have thicker walls, they don't have valves, and they carry blood under higher pressure and are primarily responsible for the maintenance of blood pressure. Okay. Very important. And then the capillaries lie between the arteries and the veins, and the capillaries are very thin walled and are for exchange. Okay. Exchange of oxygen for CO2, nutrients for waste products. Okay. Exchange of heat. All right. Exchange of water and electrolytes. All of that. And the capillaries are so numerous, we don't even bother to name them. All right. If you were to just outline all the capillaries in the body, you would have a perfect drawing of the body. They're that extensive. Okay. All right. The cardiac cycle is simply what happens during a single heartbeat. Diastole is when the chamber is maximally full. So we call that max fill. Okay. And systole is max squeeze. Okay. The phases of the cardiac cycle shown here, right? We have the atria filling, all right, passively. And then we have the pressure in the atria building above what it is in the ventricles. And then passive filling by gravity fills over 80% of the ventricle volume. And then the atria squeeze, you can see them squeezing here simultaneously, and eject the remaining amount into the ventricles. And then the ventricles squeeze, all right, and they build pressure in the lower chambers, the discharging chambers, and that ejects the blood into the pulmonary trunk and the aorta at the same time. Okay. So, like I said, there's always fluid in the chamber. It's just that the amount of fluid in each chamber changes depending on whether it's squeezing or relaxing. Okay. So, let's take a look at the cardiac cycle in a little bit more detail.
Ventricular contraction causes the atrioventricular valves to close, which signals the beginning of ventricular systole. The semilunar valves were closed during the previous diastole and remain closed during this period. Continued ventricular contraction increases pressure in the ventricles above the pressure in the aorta and pulmonary trunk, causing the semilunar valves to open. When the ventricles relax and their pressures drop, blood flowing back toward the relaxed ventricles causes the semilunar valves to close, which is the beginning of ventricular diastole. Note that the atrioventricular valves remain closed. When the pressure in the ventricles becomes lower than the pressure in the atrioventricular valves open and blood flows into the relaxed ventricles. This accounts for most of the ventricular filling. The atria then contract and complete the ventricular filling.
Normal pressures, right atrium, a mean of 4 millimeters of mercury, right ventricle, systolic pressure 24, end diastolic 4, left atrium, 7 millimeters of mercury, okay, left ventricle, systolic 130, end diastolic 7, okay. So you can see clearly based on these pressures, right? Look at the pressures on the right side, okay. Let's do this in yellow. Pressures on the right side are lower, right? And the pressures here, left side, are higher, right? Okay. Because, what did we say earlier, right? The left atrium, let's do this in red, represent the oxidation state, where left atrium is to the body, left side of the heart. Okay. Whereas the right side of the heart, represented by blue, to represent the oxidation state, is to the lungs. Okay. There you go. Right. Perfect reflection. Right coronary artery features the conus, the right marginal branch, and the posterior descending branch. This is the coronary circulation, which is the blood supply to the heart itself. To the heart wall. Okay. Left coronary artery, left anterior descending artery, circumflex artery. There's collateral circulation to ensure, in the event of a blockage, that the blood can go around that particular block and still perfuse most of the heart wall. The exception to this, the right and left coronary arteries. Okay. The reason, all right, There is no collateral circulation. If one of them gets blocked, a portion of the heart wall, if it's deprived of blood for a significant period of time, is going to die, and there will be no recovery of that muscle tissue because cardiac muscle tissue does not regenerate. It gets replaced by scar tissue, and that makes the heart weaker from that point on. Okay, that's why the right and left coronary arteries are sometimes given the nickname the widowmaker. Widowmaker. Okay. We have coronary capillaries and we have the coronary veins, okay, including the coronary sinus, the great cardiac vein, the posterior vein of the left ventricle. And what they do is deliver blood back into the right atrium from the heart wall, okay. And then there are lymphatic vessels also that drain. So if we look here, okay, you can see all these different vessels, right? You could see right here, let's do it again in red for the blood supply out, okay? The right and left coronary arteries, okay? There's the left coronary artery. There's the right coronary artery, okay? All right. They come off of the base of the aorta, okay? Okay. And then they branch extensively throughout the heart wall, right? You can see it branching off into the right marginal, okay? And giving off the posterior interventricular, all right? So these are RCA branches, RCA branch. Okay. Okay. See that? And then you've got the anterior interventricular. That's a left coronary artery branch. Okay. Giving off the circumflex, another left coronary artery branch. Okay. And then the left marginal, also left coronary artery. All right. And together they perfuse the entire heart wall. And then what do we have? We have three big veins here that drain back into the coronary sinus. Okay. The great cardiac vein, the middle cardiac vein, okay, and the lesser cardiac vein, small cardiac vein. Okay. Those all drain into the coronary sinus, all right, which dumps into the right atrium. Okay. All right. The heart is capable of generating its own action potential and regulating its own rhythm. However, the heart is under both sympathetic and parasympathetic autonomic control. Okay. Sympathetic autonomic nervous system through adrenergic nergic, thank you, postganglionics. Okay. And parasympathetic through the vagus nerve. Which is, remember, cranial nerve 10. Okay. Under sympathetic stimulation, the heart rate speeds up, the force of contraction increases, okay, and the cardiac output, which is let's put that equation down here, cardiac output equals heart rate times stroke volume. The cardiac output goes up, okay. Under parasympathetic innervation, we slow the heart rate. We have no effect on the force of the contraction, but the cardiac output goes down. Okay, so cardiac output goes down, cardiac output goes up. Okay. The conduction system is made up of the SA node, the AV node, the bundle of His, right and left bundle branches, and the Purkinje fibers. All right. So I know it sounds strange, but if every nerve lead to the heart were cut, the heart would still beat. And actually, the heart rate would go up from a resting rate of 75 to a resting rate of 100 because our resting heart rate actually reflects the braking activity of the vagus nerve that keeps it around 75 or so. Okay. The generation of these action potentials is produced as a result of pacemaker cells, which are modified cardiac muscle cells that generate their own spontaneous action potential because they have leaky ion channels in them. Okay. Let's look and see how the cardiac conduction system actually works.
Action potentials originate in the sinoatrial node and travel across the wall of the atrium from the sinoatrial node to the atrioventricular node. Action potentials pass slowly through the atrioventricular node to give the atria time to contract. They then pass rapidly along the atrioventricular bundle, which extends from the atrioventricular node through the fibrous skeleton into the interventricular septum. The atrioventricular bundle divides into right and left bundle branches, and action potentials descend rapidly to the apex of each ventricle along the bundle branches. Action potentials are carried by the Purkinje fibers from the bundle branches to the ventricular walls. The rapid conduction from the atrioventricular bundle to the ends of the Purkinje fibers allows the ventricular muscle cells to contract in unison, providing a strong contraction.
So the way that we look at this, okay, this electrical activity of the heart is through what's called an EKG or an ECG. They both mean the same thing, right? I mean electrocardiogram, okay? ECG or EKG. Okay. Now, what do we learn from an electrocardiogram? Okay. We learn the strength of the electrical signal. We learn the speed of the electrical signal. And we learn the direction of the electrical signal, okay, with respect to the electrodes that are placed around the heart on the patient, okay? The strength is reflected by the height of the wave. The higher the wave, the stronger the signal. The speed is reflected by the spikiness of the wave. The spikier the wave, the faster the signal. And the direction is reflected by the deflection of the wave, okay? The resting membrane potential undergoes a series of electrical events involving depolarization, systole, repolarization, diastole, okay, a refractory period, and then recovery. All right. The cardiac muscle tissue has a couple of features that are rare in muscle tissue. It has automaticity and rhythmicity. Okay. It means that it can generate its own action potential and then it can respond to it, which is unusual. Okay. We see this in cardiac muscle tissue and we see this in smooth muscle tissue also. Okay. Now, if we look at an EKG, all right, let's look at it. All right. The video here on the right is going to show you two things at the same time. All right. It's going to show you the EKG on the bottom and the electrical wave in this little outline of the heart. So let's watch. Okay. Let's look at the electrical wave first. Okay. So the SA node fires. All right. And what you're going to see right after that is that the atria contract. Okay. So that's the P wave. That's the first wave you're seeing, that little bump, that first one. All right. The AV node has now captured the signal. Now watch what happens next. Okay. It goes very rapidly down to the apex of the heart. Okay. And then it radiates up the Purkinje fibers. All right. That spike there is the QRS complex. All right. And then that's followed by ventricular systole. Okay. The ventricle squeeze at the same time. And then a repolarizing wave, the T wave, radiates from the apex up to the base. All right. And the two lower chambers go into diastole. Okay. So the heart rhythm, if you want to think of it like a like a song or a beat or a chant, is always depolarize, squeeze, repolarize, relax, depolarize, squeeze, repolarize, relax. First for the atria, then for the ventricles, over and over until you die. Okay? That's it. Okay? The P wave, all right, is atrial depolarization, followed by atrial systole. The QRS complex is ventricular depolarization, followed by ventricular systole. The atria are also repolarizing and relaxing in this spike, but the electrical signal is too weak to see. Okay. And then the T wave is repolarization of the ventricles, followed by ventricular diastole. Okay. And so that completes the process. We'll run it one more time. Okay. Let's run it one more time. So you can see there, okay, the P wave first, atrial systole, AV captures, blood goes from top to bottom of the heart, okay, QRS complex, up the Purkinje's, ventricular systole, okay, T wave, ventricular repolarization, and ventricular diastole follow, okay, over and over and over again. Now, an important point, right, with an EKG is that the waves have to be present, and then there have to be certain distances between the waveforms on a readout in order to know that the heart is doing its job properly. Okay, so not only is it important that we see the P wave, the QRS complex, and the T wave, all right, it's also important that these intervals are within normal range. Okay, so you can see the ranges here for PR between 0.12 and 0.2 seconds. For QRS, under a tenth of a second. The QT interval, under 0.38 seconds. Okay, and then there's segments, right? The ST segment, the T wave. Okay, and then the QRS wave here, right? And so we use that again as a way to determine whether or not the cardiac conduction system is working properly, right? That's why we do an EKG, all right? Cardiac innervation, as we already discussed, is through sympathetic and parasympathetic innervation of the autonomic nervous system. Okay, sympathetic innervation is going to cause the cardiac output to increase because the force of contraction and the heart rate will go up. Parasympathetic innervation will reduce the heart rate and have no effect on the force of contraction, and the cardiac output will go down. Okay. Beta adrenergic receptors for norepinephrine or epinephrine respond to sympathetic innervation, and that's what increases the cardiac output. This is all part of the fight or flight response. You have to increase the cardiac output in the fight or flight response in order to mobilize blood flow to heart, lung, and skeletal muscles sufficiently to deal with your situation. Okay, that's the function of it. Okay, and then once the situation is resolved, all right, it takes until the time that the epinephrine in the bloodstream from the adrenal medulla is cleared for the heart rate to settle back down to its resting rate and your cardiac output to go back down to its resting rate. Okay. Myocardial cells are similar to skeletal muscle cells in that they are striated, but they only have one nucleus. They're extensively branched, okay? And they don't have triads. Instead, they have dyads. And they are uniquely capable of autorhythmicity, okay? They do contain sarcomeres. Actin and myosin are the contractile proteins, just as in skeletal muscle. And they're connected by intercalated discs, which are combinations of desmosomes and gap junctions. The desmosomes hold the heart muscle tissue together so it doesn't fly apart while the heart is pumping, and the gap junctions allow the flow of current rapidly from one heart muscle cell to the next in order for the current, the wave, the electrical wave, to be sustained. Okay. Actin and myosin are the contractile proteins. Troponin and tropomyosin are basically the control proteins in the sarcomere, just as in skeletal muscle. And it has the same setup in the sarcomere as we've seen before, with an A band, an I band, a Z line, an M line, troponin, T, I, and C. Okay. Myocardial metabolism is primarily aerobic for obvious reasons. Okay. We don't want the heart to ever get to the point as a result of stimulation that it has to resort to anaerobic respiration, because that would interfere with the proper conduction of current through the heart wall and would lead to the heart quitting pumping. Okay. Myocardial oxygen consumption is extensive. Okay. You can see here how the cross bridges are set up in myofibrils, which are the protein components that generate the contraction in cardiac muscle. You can see that there's an interdigitating arrangement of actin and myosin. Okay, the myosin is stabilized in the middle of the sarcomere at the M line, and the myosin heads are capable of engaging ATP, hydrolyzing it, capturing that chemical energy, and then using that to bind to actin and pull on it, then ejecting the breakdown products of ATP and repeating the process. Okay. When the sarcomere is not contracting, all right, we have tropomyosin in between actin and myosin to block the formation of cross bridges. But when calcium and ATP are available, then cross bridging will occur unless we run out of one or the other. Okay. You can see that the Z disc is attached to the actin tropomyosin complex. All right. And it also helps to stabilize the position of the thick filaments as well. Okay. You can see where the H band is. That means hypochromatic band in the middle of the sarcomere. All right. The A band is simply the length of the thick filaments, and that never changes. All right. And then you have the Z discs and the I band. Okay. The I band represents the portion of the sarcomere that contains no myosin. All right. And the Z discs, of course, are the stabilizing structures that are attached to the actin and the tropomyosin. Okay. So when a sarcomere engages in contraction, all right, the H bands narrow and the I bands narrow. Okay. And then when it relaxes, the H bands widen and the I bands widen. Okay. So essentially, what happens during contraction is that the amount of overlap between the thick and the thin filaments increases. And that's where the power generation comes from. Okay. There are proteins that are connected from the myofibrils to the muscle cell membranes. And then, of course, that's connected by connective tissue to the cardiac skeleton. All right. Which is essentially a type of connective tissue that is bound to the cardiomyocytes that forms the outline of the heart chambers and the heart valves. Okay. And so that's really what we're squeezing on. Okay. So you can see here how we form the actin and how the tropomyosin comes into play, right? When troponin binds calcium, tropomyosin pivots out from between actin and myosin, and then cross bridging will continue until we run out of either ATP or calcium inside the cardiac muscle cell. Okay. And then you can see the cross bridge cycle down there at the bottom. Okay. Engaging ATP to cock the head, reaching up and gripping. Okay. And then as we kick out the breakdown products of ATP, we do the power stroke, and then we release when we bind another ATP, and then we repeat over and over again. Okay. Cardiac output is simply the heart rate times the stroke volume. Okay. The preload is the amount of pressure inside the ventricles at the end of diastole. It is basically the left ventricular end diastolic volume. Okay. The Frank-Starling law of the heart simply states that the greater the preload, the more powerful the force of contraction. Another way of stating that is that the more blood that goes into the heart, the more blood comes out of the heart. All right. And of course, that would have to be the case, because if it weren't, the heart would explode. Okay. But the reason for the more powerful contraction is the increased overlap of actin and myosin to improve the amount of cross bridging that takes place, and as a result, increase the power of the squeeze. Okay. In addition to that, of course, when that occurs, that's generally under sympathetic stimulation, and that makes more calcium available, which makes for more cross bridging and a more powerful contraction as well. The afterload, as we already stated, is simply the resistance against which the heart has to work. All right. And there are many things that contribute to afterload. Okay. If the afterload is too great for the heart to overcome, that's the definition of congestive heart failure. All right. So this is the load that the muscle has to move after it contracts, and it's determined by systemic vascular resistance in the aorta. Okay. Which is essentially a sum of the resistance throughout the body. Right. Myocardial contractility involves the stroke volume and the preload. Okay. The greater the contractility, the greater the stroke volume. The greater the preload, the greater the stroke volume. Okay. Ionotropic agents have an effect on this by either increasing or decreasing the amount of calcium available for the generation of the action potential and the production of the cross bridges. Okay. Oxygen and carbon dioxide levels are also critical. The cardiac output, again, is the heart rate times the stroke volume. Okay. The ejection fraction is just the stroke volume over the end diastolic volume. All right. And so the greater the ejection fraction, the greater the cardiac output. Okay. So you can see there all the things that play into this. All right. Okay. The heart rate is under cardiovascular vasomotor control centers. In the brainstem, there are cardioexcitatory and cardioinhibitory centers that are triggered by input that comes to them from the heart, all right, and from things like oxygen levels in the blood as well as blood pressure, okay. Neural reflexes include the Bainbridge and the baroreceptor reflex. There are atrial receptors for stretch, which can trigger the production of atrial natriuretic peptide, which can reduce blood volume and blood pressure by increasing urine output from the kidneys through allowing more sodium to remain in the filtrate. Okay, so this acts as an antagonist to aldosterone. All right. And then there are other hormones and biochemicals. Let's go through the Bainbridge and the baroreceptor reflexes. Okay, the Bainbridge reflex, also called the atrial reflex, is a compensatory mechanism that causes an increase in heart rate when central venous pressure increases. Stretch receptors in the atria detect the increase in blood volume. This causes the heart rate to go up. A Bainbridge reflex is a fundamental principle in cardiac physiology. Now, the baroreceptor or arterial baroreflex is a series of quick actions that regulate blood pressure during short-term events, such as changing position from seated to standing. The reflex works by monitoring sudden changes in blood pressure and modulating the heart rate and vascular resistance to dampen those changes. This maintains blood pressure within a normal range. Okay. The systemic circulation, again, composed of arteries, veins, capillaries. Arterioles lead into capillary beds, venules drain capillary beds. A blood vessel is simply made up of a variety of tissue layers. Okay, the tunica intima is endothelial tissue lined with prostacyclin to prevent the rupturing of formed elements of blood. Okay, the tunica media is smooth muscle tissue, and the tunica externa is connective tissue. All right, so because of that, we can actually consider the blood vessel a bona fide organ. All right, if we look here in a little bit more detail, you can see that the arteries and the veins have the same basic three tunics, all right? But the amount of tissue in each is a little bit different, right? In veins, we have endothelial one-way valve flaps to promote the one-way flow of blood from the veins back to the heart, all right? And we lack that in arteries. We have a thinner tunica media, all right? And we have a thicker tunica externa, and we have larger lumens in veins. That's why they're called capacitance vessels, and they actually contain most of your blood supply from moment to moment. Okay. The arteries have a thicker tunica media. All right. They often have elastic connective tissue between their layers, especially in the larger arteries, and that is to smooth out fluctuations in pressure. Okay, you can see that in yellow there. Okay, and they have a thinner tunica externa. Okay, note that the externa is there to latch the blood vessels in place so that they don't twist, buckle, or kink and cut off blood supply. All right. The blood flow back to the heart, which we call the venous return, is controlled by a few things. All right. It is controlled by the skeletal muscle pump and the respiratory pump and the one-way valves and the smooth muscle in the walls of the vessels. Okay. So the skeletal muscle pump works as seen here. As you move, you squeeze the veins, you push blood through one-way vessels, and that helps to move the blood back up towards the heart, ultimately into the inferior and superior vena cava, okay, which will ultimately dump into the right atrium. The respiratory pump is the fact that you breathe, and when you breathe, you milk the inferior vena cava by producing pressure changes, and that helps to move blood up through one-way valves and back up to the heart. And then we also have a little bit of smooth muscle help in the tunica media to help push the blood back towards its intended location. Okay. Sometimes the valves in veins that are below the heart can become incompetent. And if they do, they will collapse. And then you'll get a bulging vein, which is called a varicose vein. Okay. And varicose veins, in addition to being painful sometimes and unsightly, are a clot risk. And that's one of the reasons why people will often have them removed. Okay. The factors that affect blood flow include pressure, okay, which is the force that a liquid exerts on the walls of its container, the resistance, which is the opposition to flow, diameter and the length of the blood vessels are the major contributors, okay. The most important contributor is diameter, okay. The diameter of a blood vessel um, has an effect on resistance to the fourth power of the radius. Okay, so if I had a blood vessel that decreased its radius by half, all right, the amount of resistance would go up 16-fold. All right, because 2 times 2 times 2 times 2 is 16. Okay. The longer the blood vessel, the greater the resistance as well. Okay. And the less numerous the blood vessels, the greater the resistance. Okay. Pucel's law says that the flow rate depends on viscosity, pipe length, and the pressure difference between the two ends. Okay. So what is this telling us, right? Um, the more viscous the blood, the greater the resistance. The longer the blood vessel, the greater the resistance. And the the less the difference in pressures, the lower the flow rate is. Okay. So it's if we were to write the formula out here, let me find it, pull it up. Okay. So Q is equal to pi r to the fourth, right? Times pressure to times pressure, I believe, to the eighth power times n, which is the length of the vessel, times, or sorry, n, which is the viscosity, times L, which is the length of the vessel. Okay. So I can list those, right? L is length of vessel. R is radius. Okay. Um, N is viscosity. Okay. P is pressure. Okay. And then Q is flow. Okay. You can see the baroreceptor and chemoreceptor reflexes. All right. Essentially, what we're saying here with this is baroreceptor up top, upper left, all right, is that as blood pressure goes up, all right, we have input from nerves from the cardiac innervation, all right, via the stretch receptors, all right. We send that information back to the brainstem, all right, and then we end up via the vagus nerve reducing the cardiac output. Okay. So these receptors are in the glossopharyngeal nerve in the carotid and aortic bodies. Okay. Vagus nerve in the picks up the aortic baroreceptor, glossopharyngeal, the carotid. We send that to the brainstem, and the vagus slows the heart down. Okay. We have cardiac nerves that feed into the paravertebral ganglia of the sympathetic nervous system. All right. I'm sorry. We have output from the paravertebral ganglia of the sympathetic division of the autonomic nervous system, which is going to do the opposite. Okay. It's going to increase the rate and the force of contraction. Okay. When the blood pressure drops. All right. And it's also going to promote vasoconstriction. All right. And that's going to raise blood pressure. So cardiac output and peripheral resistance go up. Okay. Increase. Okay. And that's for the sympathetic part, right? Okay. And for the parasympathetic, it's as indicated up here. Okay. Okay. Down. Peripheral resistance goes down. Okay. And then you can see below here, chemoreceptors respond to pH, CO2 and oxygen levels. Bottom line, all right. When oxygen levels decline, CO2 levels go up, pH goes down. What's going to happen? We're going to get chemoreceptor input to the brainstem, and then we're going to get output to increase the cardiac output, all right, and to increase smooth muscle tone in the vasculature, okay. And the result of that is the blood pressure is going to go up, all right. More blood is going to go to heart, lung, and skeletal muscle, and we're going to increase the oxygenation levels of the blood. At the same time, removing the CO2 and increasing the pH. Okay. So chemoreceptors, baroreceptors. Okay. Okay. Blood flow is affected by viscosity as well. All right. The more narrow the vessel is, the greater the drag of the fluid on the walls of the vessel and the slower the flow. All right. Which is why a wide diameter vessel is going to have a faster mean flow than a narrow diameter vessel. Okay. Turbulent flow is slower blood flow. Slow blood flow, the danger of that, of course, is that it can lead to blood clots. All right. Compliance is just the ability of the blood vessel to accommodate the flow and the pressure changes. Okay. So it's basically the stretchability of the vessel. All right. Regulation of blood pressure. Okay. The mean arterial pressure, all right, is calculated as, okay, the pulse pressure is I gotta get this right. Pulse pressure is the systolic minus the diastolic. minus the diastolic. That equals the pulse pressure. Okay. The map is equal to the diastolic plus 1/3 the pulse pressure. Okay. Why do we care? If the map is too high, that puts extra strain on the capillary beds and can force them to burst, which is very bad, right? This is going to affect cardiac output. The higher the map, the lower the cardiac output. Okay. It affects peripheral resistance, right? The lower the map, the less the peripheral resistance. Okay. There are effects that are that have to do with hyperemia. Okay. For instance, when you exercise, muscle is able to overcome the natural tendency for blood flow to be reduced. Okay. Hormones, epinephrine and norepinephrine, are going to have an effect on pressure. Epinephrine and norepinephrine are going to raise blood pressure systemically because they're going to promote increased flow to heart, lung, and skeletal muscle, but they're going to decrease flow to GI, urinary, and reproductive. And so the net effect is to raise blood pressure. All right. So let's put that in there. So raise BP. Okay. ADH and aldosterone are part of the renin angiotensin aldosterone system. Okay. How does this work? All right. Well, as blood pressure goes up, okay, the kidneys produce renin. Okay. Renin converts angiotensinogen into angiotensin 1. And then in the lungs, ACE is going to convert angiotensin 1 to angiotensin 2. Okay. All right. Now, so this is ACE converted. Now, what does angiotensin 2 do? Well, angiotensin 2, AT2, promotes the following: thirst, vasoconstriction, and production of ADH and aldosterone. And all of this raises your blood pressure. Okay. Which is why people that have hypertension take a series of drugs known as ACE inhibitors. All right. Reducing the amount of angiotensin 2 in your system is going to drop your MAP and drop your blood pressure. Okay. So you can see here all the different ways that these work, how they're all tied in. Okay. Other mediators include nitric oxide, a naturally produced vasodilator that regulates blood pressure by controlling vascular tone. When nitric oxide production is impaired, endothelial dysfunction occurs, which is a risk factor for hypertension and cardiovascular disease. Research suggests that loss of nitric oxide production is one of the first events in hypertension. Okay. Adrenomedullin is a hormone that regulates blood pressure and vascular tone. It's released from the vascular wall and acts as a paracrine or autocrine hormone. ADM is a powerful vasodilator, reducing blood pressure. When administered by IV, it has been shown to lower blood pressure and increase heart rate and cardiac output. Okay. All right. Let's take a look at the physiology of coronary circulation.
Without ads, you're going to have access to the notes for each lesson And I do actually have a little surprise with these notes for members of the Academy. That's something that's going to be coming up here soon. But along with that, you're also going to have access to the audio-only versions of these lessons. The best part, though, is you're going to be able to earn CE credits for watching these lessons and then passing a quiz at the end of them. So follow the link in the description or head over to icuadvantage.com/academy to pre-order while you still can before March 15th for 50% off that lifetime access. Now, to go along with knowing the vessel structure and the areas of the heart that they perfuse, we also should talk about the physiology that serves as the driving force behind how and why we meet the demands of the heart. So, to begin this discussion, let's actually start talking about just blood flow in general. So, the heart has the highest demand for oxygen than any other organ in the body. In fact, the heart has the highest A to VO2 difference, meaning that blood leaving the heart has a significant amount of oxygen that's used. Anywhere from 60 to 70% of the oxygen that makes it to the heart ultimately ends up being used up, and this is even at rest. As a result of this, the amount of blood that's delivered to the heart can actually be quite high. In general, about 5% of our cardiac output is specifically going to the heart. Now, at rest, the heart gets about 250 to 300 mLs per minute of blood, but once the demand increases, the blood also does rapidly and quite largely. So during exercise, we can see the blood flow increase to upwards of 1,000 to 2,000 milliliters per minute. Now, the microcirculation, which if you remember are those very small vessels that plunge deep into the myocardium, these are what are responsible for the changes that really regulate coronary blood flow. Now, I'll be talking more in depth about this in just a minute here. And then, as discussed in that lesson on the anatomy of the coronary circulation, remember that the heart is primarily being perfused during diastole. And the reason for this is that during systole, the heart is contracting, and thus the contraction of the cardiac muscle also constricts and squeezes the blood vessels of that microcirculation. So this not only leads to no flow, aka no perfusion, but it can also lead to some mild retrograde flow. Just an interesting point. Now, that said, all of this is mostly true for the left side of the heart, so the areas perfused by the left coronary artery. Now, both the right coronary artery and the left coronary artery are fed off the aorta, and thus they have the aortic pressure perfusing blood. Now, the pressure in the left atrium and especially the left ventricle during systole prevent the forward flow of blood. These pressures then drop in diastole, and then the aortic pressure overcomes these pressures, and thus we have forward flow that's resumed. Now, the right coronary artery is feeding the right side of the heart, and this is actually not diastole dependent. And this is because the aortic pressures exceed even the low pressures seen in our right heart. So this actually leads to a more uniform rate of flow of blood throughout the right coronary artery. Now, patients who have ischemic coronary artery disease that really has progressed slowly over time, that they can have a process called angiogenesis take place, and this is something that we also refer to as the formation of collateral circulation. So this is where new blood vessels are formed that run parallel to current stenosed vessels, thus increasing coronary blood supply and reducing coronary vascular resistance. Alright, so that's the basics of the blood flow. Let's move into something that we term active hyperemia. So the blood flow to the heart has a very tight relationship with the oxygen demand of the heart. When cardiac activity and thus oxygen consumption increases, the coronary blood flow also increases as well. This is something that we call active hyperemia. So the ventricular rate, the pressures, and the contractility all factor into the workload of the heart and thus the oxygen consumption. Now, because the heart at baseline extracts such a large percentage of the available oxygen, there's only a little room left to buffer any increased demand with the remaining oxygen that's left in the blood. This means that increasing blood flow is the primary way in which oxygen delivery can be increased to meet this increased demand. So a combination of downstream metabolites of oxygen consumption, along with local hypoxia causing the release of vasodilatory substances are what are primarily responsible for this regulation and active hyperemia. Now, sympathetic and parasympathetic activations do also play a role in this process as well. So, increased sympathetic activity leads to increased cardiac output and thus increased myocardial oxygen demand. Now, we do actually see some mild transient vasoconstriction here due to the alpha 1 activation on the blood vessels, and this would actually normally be counter to needing to increase myocardial blood and oxygen supply. This response, though, is short-lived, as the increased workload of the heart is going to trigger vasodilation via our active hyperemia. Again, I'm going to go more in depth into this in just a minute here, but this is a result of activating our beta-1 receptors of the heart, leading to the increased workload of the heart that we see. Now, when it comes to our parasympathetic in our rest and digest mode, the workload of the heart is reduced. This is reducing the oxygen demand and thus the need for blood. Now, again, initially, like with the sympathetic response, we do see an opposite reaction as our vagal stimulation is going to lead to mild vasodilation of the coronary arteries, but the parasympathetic activity is typically going to lead to decreased activity of the heart, and thus this is going to reduce oxygen consumption, leading to a reduction of our vasodilatory mediators being released as a result of our active hyperemia. So this means vasoconstriction is going to take place, increasing our vascular resistance and thus decreasing blood flow as it's no longer needed at this point. All right, and then lastly, let's talk about these vasoactive mediators. So now that we've talked about the process of increasing and decreasing blood flow based on the oxygen demand of the heart, let's talk a little about how all that works. So first we have oxygen and CO2. And simply, our local hypoxemia and hypercarbia do lead to vasodilation. Now, that said, even with increased workloads, studies have actually shown that typically there's little change in coronary venous PO2 and PCO2. And so this tells us that the regulatory mechanisms work so well that generally a healthy heart can rapidly maintain these levels as the workload increases and decreases. Next is going to be adenosine. And adenosine actually plays a very important role in our active hyperemia and our autoregulation. So its formation is actually increased when hypoxia and increased oxygen consumption takes place through degradation of ATP. So if you think of the name, adenosine triphosphate. And this is even more so when there is an increase in oxygen demand that's really not satisfied by the oxygen supply. And so the presence of adenosine in the coronary vessels actually leads to vasodilation. And this is believed to be one of the stronger mediators in this process. Now, nitric oxide also plays an important role as a vasodilatory mediator. So it serves as a direct receptor-mediated vasodilator, and it also serves as an indirect vasodilator by inhibiting the effects of angiotensin II, as well as our sympathetic vasoconstriction. Now, nitric oxide is released by our vascular endothelium, and when it is diffused into vascular smooth muscle, it leads to increases in cyclic GMP, which ultimately causes smooth muscle relaxation and thus vasodilation. And then finally, we have endothelium. And endothelium is actually a potent vasoconstrictor, especially in the coronary vessels. Increased levels have actually been found in cases where the physiology would indicate a decreased myocardial oxygen demand. Therefore, we want to see that vasoconstriction to slow down the blood flow going to the heart because it's really no longer needed at that point. And so those are the different mediators that we know of. There are some other potential ones out there that are believed to play some roles, but these are kind of the major ones that I wanted to discuss here. And really overall to talk about, the process of why that blood flow is important, how it's regulated, again, with that active hyperemia, how that all plays into increasing and decreasing the blood that's going to the heart based on the workload of the heart, the oxygen demand that's going on, because really the primary way that we drive increasing or decreasing the oxygen to the heart is by increasing or decreasing the blood flow. So I hope that you guys found this information useful. If you did, please leave me a like on the video down below. It really helps YouTube know to show this video to other people out there, as well as leave me a comment down below. I love reading the comments that you guys leave, and I try to respond to as many people as I can. Make sure you subscribe to this channel if you haven't already, and a special shout out to the awesome YouTube and Patreon members out there. The support that you're willing to show me and this channel is truly appreciated, so thank you guys so very much. If you'd be interested in showing additional support for this channel, you can find links to both the YouTube and Patreon membership down below. Head on over there and check out some of the perks that you guys get for doing just that, as well as check out some of the links to other nursing gear, as well as some awesome t-shirt designs I have down there as well. Make sure you guys stay tuned for the next lesson that I release. Otherwise, in the meantime, here's a couple awesome lessons I'm going to link to right here. As always, thank you guys so much for watching. Have a great day.
Now, the lymphatic system is designed to take the 15% of fluid volume left behind at every capillary bed in the body every minute of the day, and then force it into one-way valves that open from tissue into vessel, and ultimately to lymph nodes. And in the lymph nodes are lymphocytes and macrophages designed to attack and destroy cancer cells and pathogens. Once that fluid has been treated, those pathogens have been dealt with, the remaining fluid leaves the nodes and eventually enters the right and left subclavian veins, the right thoracic duct dumping into the right subclavian vein, and the thoracic duct dumping into the left subclavian vein. We should also note that the thoracic duct also receives the fatty lymph known as chyle from the digestive system in order to introduce it into the blood supply and ultimately get it to the tissues and the liver. Other lymphatic organs include the tonsils, the spleen, the mucosa-associated lymphatic tissue, and the thymus. All right. Notice that the spleen is designed as a blood reservoir. It also helps to recycle red blood cells, but one of its roles in the lymphatic system is to remove pathogens and cancer cells from the blood. The mucosa-associated lymphatic tissue, of course, is found in the linings of the respiratory, the GI, the urinary, and the reproductive. And it is a collection or collections of macrophages and lymphocytes designed to pick off pathogens that leak through the epithelial linings of these systems before they get into the blood supply. The tonsils, of course, are there to deal with inhaled or ingested pathogens. There are crypts in the connective tissue of the tonsils where macrophages and lymphocytes lie in wait for pathogens and cancer cells, which they intercept and destroy. And then in further turn, they recruit the appropriate lymphocytes to fight those pathogens should they be encountered elsewhere in the body. And the thymus is essentially where T cells are rendered immunocompetent after they're generated in the red bone marrow. They move to the thymus and they're selected for the ability to tolerate our own antigens and attack foreign antigens, and then released to the secondary lymphatic organs, which are, again, the tonsils, the lymph nodes, the spleen, the malt, and the galt, okay, throughout the body, so that they can do the job of defending against disease and cancer, okay? Pathogens and cancer bear molecules on their surface known as foreign antigens, which alert our adaptive immunity, which are our lymphocytes and our macrophages, to respond and clear the foreign antigen, both in infected tissue and outside infected tissue. While, of course, our other protective components, which aren't technically part of the lymphatic system, our cutaneous membranes, our mucous membranes, our inflammatory response, fever, the action of our granulocytes, all serve to cut down on the pathogenic load that the lymphatic system would otherwise have to deal with. Okay. All right. So let's take 15 and then we'll come back for the next chapter and we'll deal with disease processes.